A very good evening to everyone. Good evening to all the Bacha Party, and I hope you are doing well, and I hope you are back on track, you are studying, you are putting in all the efforts that you need to, right? And we are very excited to be here again in this integrated MCQ rounds. This is a really interesting thing to do, for us faculties to sort of come together, discuss some cases, and talk about various aspects from clinical presentations to how do you work up a case, what would be the treatment, So this is, I think, integrated MCQ rounds is super fun even for us sitting here on the other side. So a very warm welcome to each one of you. And this is the second integrated session for OBGY and radiology, and we thought of doing something which is sort of very high yielding for all exams. So it doesn't matter, whether it is INI-CT or it is NEET PG or it will be NExT. So whatever it is, this is a topic which has been repeatedly asked in various formats. We had a recent question as well in the NEET PG exam. So, we thought of doing this topic together and making it more fun and interesting for you. So, since it is an MCQ round, so we are going to primarily start with MCQs, look at certain aspects, tell you certain things. So, I will cover the gynecological aspects of, the Mullerian anomalies that you should know. And after each MCQ or anomaly, Dr. Sumer is going to come here and discuss the radiological aspects of that anomaly as well, right? So that's how we plan to do the sequence. And in the end of the session, I would summarize the clinical aspects that you need to know as well as take-home message. So is everyone ready? No, it's not difficult at all. It is a very interesting topic. So are you all ready? Yes? So I'm going to train you well. Don't worry. Okay, so let's look at this. So we're going to go on with the MCQs first. So let us look at the first question for the day. So the first question for the day is, you have a 22-year-old woman who is consulting us regarding her history of recurrent pregnancy loss. So that is the key presentation of my patient. She has recurrent pregnancy losses. Her gynecological history is otherwise unremarkable, and during examination we note that a uterus is markedly deviated, right? So that's again a second important term that you need to know. It is markedly deviated. A transvaginal ultrasound and 3D images are done, and the image is being revealed to you, and it shows a deviated uterus that has a banana-shaped cavity. So there comes the third keyword for you, right? So now, once we have identified the keywords, you also have a 3D image in front of you. So this is a 3D ultrasound image. Okay, so that's a 3D ultrasound image. And now that we have the keywords together, so as I said, the first keyword is recurrent pregnancy loss, and a markedly deviated uterus, and a banana-shaped cavity. So yes, you're all right, absolutely. So this is a uniconnuate uterus. So uniconnuate uterus has been a persistent MCQ in NEET PG exams. It has multiple times comes as an image-based MCQ as well, right? So quickly, we need to understand a few things. So pehla doubt hai that, you all know that when you talk about recurrent pregnancy loss, we talk about which kind of anomaly? Septate uterus. So that is where you can go wrong. हमें ना absolutes नहीं देखने हैं. So although yes, RPL is highest with septate uterus, okay, but please remember recurrent pregnancy loss can be seen with all other Mullerian anomalies. So yes, it can be seen with uniconnuate. It can even be seen with didelphius. Okay, so it's not absolute. ऐसा नहीं होगा कि it is only seen in septate, not seen in other. So please remember, all Mullerian anomalies can actually present with RPL. So खाली RPL पढ़ के septate नहीं आंसर करना है. You have to hold on. The second important thing that I have to tell you is that it has a extremely deviated and a banana-shaped cavity. So that's characteristic. Now what we need to understand from this, apart from all these things, is uniconnovate uterus mein काफी बार the other side is going to have a rudimentary horn. So one Mullerian duct is going to form one side uterus. It is going to form the cervix. Yes, there will be a fallopian tube and the cervix would be connected to the vagina. The other Mullerian duct is going to convert into a rudimentary horn. So very often there is going to be a rudimentary horn, and this rudimentary horn may be connecting to the main uterus or it may be obstructed, right? So this rudimentary horn can be connected to the main cavity or it can be obstructed. Now, please understand this rudimentary horn can also have functional endometrium. ठीक है बच्चा? So it can also have functional endometrium. So if it has functional endometrium, can it also present with symptoms of obstruction of menstrual flow? Yes. So it can have a functional endometrium and it may be obstructed. So it will have other features of obstructed flow as well. So what are those features? So can uniconnovate uterus present with endometriosis? Yes. Your uniconnovate has a high association with endometriosis. So whenever there is going to be a obstruction, uski wajah se kya hota hai? Obstruction leads to what? It leads to retrograde menses, which is what is called as the Sampson's theory of endometriosis. So there is a retrograde menses, and whenever there is an obstruction to the outflow tract, there is going to be association with endometriosis. So it has a strong association with endometriosis. You should also remember uniconnovate uterus has a very strong association with one more thing, and that is what? That is very likely to be asked in the exams as well. A very high association with urinary tract anomalies. So मुझे पता है कि आपको पता है that all Mullerian anomalies have association with urinary tract anomalies. But among all, the highest association is with uniconnovate in the range of 40% or even higher. So high association with endometriosis, high association with urinary tract anomalies. Apart from this, yes, it can be associated with two ectopics. Okay, so uniconnovate का दो ectopic चीजों से association है. One could be ectopic ovary, a very characteristic association, and second is ectopic pregnancy. ये कौन सी pregnancy होती है? This is the pregnancy which is going to be in the rudimentary horn. Right? So this is the pregnancy which is going to be present in the rudimentary horn. So it's going to be ectopic, and for this reason, this is very risky. So it can actually cause a rupture which will have a significant blood loss. Right? So remember, it is associated with two ectopics, ectopic ovary, ectopic pregnancy. इसके अलावा when we want to give you uniconnovate uterus in the exams, क्योंकि here बच्चा पार्टी, the uterus is extremely deviated. What's characteristic to the dysmenorrhea? Can you tell me? So dysmenorrhea is something that people, very often have as primary dysmenorrhea as well. Now, in this case, even if it is primary, you know what? It is because of obstruction to the outflow of the rudimentary tract. So this dysmenorrhea is not felt centrally in the suprapubic region. Normally ना बेटा हम बोलते हैं प्राइमरी डिस्मेनोरिया जो होता है वो सुप्राप्यूबिक होता है, सेंट्रल होता है. इसमें क्या होगा? क्लासिकली इट इज अ unilateral dysmenorrhea. Very, very important. We often ask this, right? So unilateral dysmenorrhea and cyclical pain is because of obstruction of the outflow of the rudimentary horn. Okay? Then, I have already talked about recurrent pregnancy losses, but now if I ask you what else can be a pregnancy complication with, uniconnovate uterus. So apart from recurrent pregnancy loss and ectopic pregnancy, what else can be a pregnancy complication with this? So the cavity is small, okay, in a uniconnovate uterus, and the cavity is small. So whenever it is small, it can cause preterm labor, right? So it can cause preterm labor, It can even cause IUGR, again because of the small size of the cavity. And what malpresentations do you think you can see in uniconnovate uterus? What malpresentation? So it is going to be a breech malpresentation. Please remember the space is less, so it will not be a transverse lie. Okay, so it will not be a transverse lie, it would be a breech presentation. And because it's only one uterus, this can definitely, and a small uterus, this can definitely also lead to dysfunctional labor. Okay, so this can also lead to dysfunctional labor. Okay, so very, very characteristic things that you should know about. What do we say? We should know about uniconnovate. Okay, so you'll remember these key things. They're all very important for your exams. Either the gynae associations or the obstetric associations for uniconnovate uterus. All right. So now I will invite Dr. Sumay to talk about the radiological aspects of uniconnovate uterus as well as to give you.
Welcome back, everybody. Now, so you have already discussed the basics of the question that Dr. Deepti has discussed about uniconnovate uterus. And I want you to know it is one of the most frequently asked question also in your INI-CET exam, or when you go to NEET PG exam. It's very, very important. And so this particular topic that we have selected for the integrated rounds today is very high yield. So what I'll do is I will go step by step. First of all, I want you to identify the investigation that you see in front of you. This investigation that you see in front of you is, let me know in the chat box, HSG. This is hysterosalpingogram. Now this is a normal HSG for you. You might be thinking, sir, abhi mujhe hi-fi padna hai, but I want you to know this is what was asked in the last year's 2020 in the NEET PG exam. They asked you to identify HSG, and many people were not able to identify. This is normal hysterosalpingogram. This is the normal uterus. I can see that most of you are aware of it. That is so nice. But exam mein fir galti kyun hoti hai? Hai na? Exam mein galti kyun hoti hai? Tell me. When you overthink on easy questions. Easy questions ko overthink nahi karna. If we have told you in the class, it is enough. You need to mark it in a second. These are your fallopian tubes. And this is, I'm going to use a orange colored arrow to show you the free peritoneal spill. So this is your free peritoneal spill that you see here. Are you clear with this? This is a normal hysterosalpingogram. Now question is, why would you do a HSG? The question is, why would you do a HSG? HSG is done to look for tubal patency in a patient with infertility. Okay. So when we are evaluating infertility, we do HSG to look for tubal patency. So the entire moral of the story is that we do not do HSG to look for Mullerian abnormalities. So many students get this question wrong in the exam and they see a question saying, what is the investigation of choice for Mullerian abnormalities? The answer is not HSG. HSG is done for tubal patency in patients with infertility. Now, what will you do? My question is, what will you do if you are suspecting Mullerian abnormality? Now, on HSG, incidentally, you can pick up Mullerian abnormalities, but if you are suspecting Mullerian abnormality, we need to evaluate further. Now, HSG can show you inside in the uterine cavity. It cannot show you the outer, the fundus. It cannot show you the contour of the fundus, which is critical when we are making a diagnosis of Mullerian abnormalities. So we need to do something which has more 3 dimensions to it. I will show you one investigation, and now I want you to identify the investigation in front of you. This is anybody wants to tell me in the chat box? This is a 2-dimensional, a routine 2D ultrasound. Okay, this is how a 2D ultrasound looks like. This is trans-abdominal scan. We can do a trans-vaginal also. This is trans-abdominal scan if you are looking at it. This is your urinary bladder. Bladder is appearing anechoic black because water-filled areas appear black. This is your uterus. And the white stripe that you see inside the uterus, I'm going to use an orange color to mark it for you. The white stripe that you see inside the uterus is your endometrium. This is your endometrial echo or endometrial stripe. Okay, so this is a sagittal section of the uterus, that how we see it on a ultrasound image. But today with ultrasound we have capability to create a 3D image as well. This is a 3-dimensional ultrasound image. You can see the endometrial cavity, and you can see the detail in it. This is the endometrial cavity, and these are your the ostial ends of the endometrial cavity. You can appreciate the contour of the uterus much better. You can see the contour here when we do a 3D ultrasound. So if they ask you what is the investigation of choice for Mullerian abnormality, the answer is 3D ultrasound. I want you to be clear here. This is a 2-dimensional ultrasound. This is a 3D ultrasound. But other than this, if we want to evaluate further, if we want to look for, concomitant renal abnormality, or if the ultrasound imaging is non-conclusive, you can go for a further imaging which can again be done in multiple planes. Can you identify this multi-planar investigation? This is a sagittal image. This is a coronal image. Anybody? This is MRI image. This is MRI image. I will show you how the MRI looks like. Okay, everybody now see with me. This is your urinary bladder, and I'm increasing the size. You can see the uterus, the cervix. But I hope you are now able to make out that in the uterus, this is your endometrium. On a MRI, this is myometrium, which is bright in signal. And between the myometrium and the endometrium, you have your junctional zone. So MRI has the advantage of multiplanar imaging, as well as it can also show you zonal architecture. I will talk about why all this is important when we talk about unicoordinate uterus. We can see the zonal architecture, we can see the endometrium, and it is important when you look at the rudimentary horn in a patient with unicoordinate uterus, you want to look for presence of endometrium, and that all can be seen on MRI. I will show you how MRI on a coronal scan would look like. This is the uterus sitting over the bladder, because this must be a anteverted uterus, so it is sitting over the bladder. We are looking at a coronal scan, and my arrows are at the ovaries. So you can see multiple follicles. This is a zoomed image, don't get confused. We are zooming it to make sure that the undergraduates are able to see it. These are your ovaries. Okay, so MRI gives us the advantage that it can show you the detailed anatomy in multiple planes. It can even show you the zonal architecture. But it would not be considered as the investigation of choice because of the high quality 3D ultrasound available today, which can show us the anatomy and answer most of the questions that we need to answer. Okay. Now I will give you the first image to solve. Okay. Now this is a inverted image. Inverted means that computer has just inverted black to white. Don't get confused. In the exam I see many student gets confused ke sir ye uterus black kyun dikh raha hai? Just that we have inverted the image. This is just like the dark mode, like you in your phone you have a eMedicoz also, you have a dark mode, a white mode, but this is the dark mode on a computer screen just to make it easy for our eyes to see. Now a uterus should have been here somewhere in the midline. What do you see here? What do you see here? Uterus is small, definitely this is small, deviated. And I'm sure when you were hearing Dr. Deepti, you heard it multiple times. She was saying it multiple times. Deviated uterus. This is your tube. Okay. So what do you see here? And if you look at it closely, it looks like a banana. A small deviated banana shaped uterus. What do you think we are dealing with? This is a unicornuate uterus. And you will be happy to know this is one of the most frequently shown visual in your exams. Okay. Now, when I'm evaluating this patient, this is the schematic that I have in my mind. So this is what is happening here. This is your vagina, cervix, one horn, one tube. Will you see it here? Okay. So this is a unicornuate uterus. In the same patient, I happen to do the IVP also. In the same patient, I happen to do the IVP also. I want you to tell me what is the IVP finding and how these two are interlinked. Anybody? So when we see the IVP, when we give the intravenous contrast, the dye is excreted. So this is your right kidney, right ureter, right, you can see the ureter till the end. What is it that you cannot see? You cannot see the left kidney. So what is there? Agenesis. Agenesis of left kidney. So do you realize that Dr. Deepti also talked about that when we see a unicornuate uterus, you should also look for renal abnormalities like agenesis. And it is very important. I have done this many times in my ultrasound. Many times the gynecologist will send the patient to me for pelvic ultrasound. Okay, and I see a unicornuate uterus or a Mullerian abnormality. Immediately I put my probe on the abdomen and look for kidneys. And then I tell them that there is an absent kidney, and the good thing is I'm not paid for it. When they do an ultrasound pelvis, they pay me half the money. If they do a whole abdomen, they pay twice the money. But even if they have not paid for it, I still do it. So this is called as value. In healthcare, you should not always look for doing things that you are paid for. You should go beyond. If you think there is a Mullerian abnormality, also look for kidneys. Okay, very important. And we did an MRI of this patient. What do you see? So this is the uterus here. Okay, I will zoom it here for you. And I just wanted to show you the value of MRI. Once you do an MRI, I don't need to do an IVP, etc. Everything is visible in one image. So look at the bladder. Over the bladder, can you see the uterus? This is your uterine horn. What do you see? Small. Is it in the midline? No. Definitely deviated, small, unicornuate uterus. But what else do you see? Anybody? What else do you see? You can see the kidney on the right side, but there's no kidney on the left side. Okay. But on the left side, we can see some follicles here. We can see some follicles here. What could it be? What could it be? And if you remember, Dr. Deepti, when she was talking about unicornuate uterus, she said multiple times a word, ectopic. So this is an ectopic ovary. So the ovary on this side has gone on an abnormal location. There's an ectopic ovary as well. So not only you have an absent kidney, you can have ectopic ovaries in unicornuate uterus. And all of this can be seen in one single image. That is the value of MRI. So MRI has a detailed evaluation available. So that you can even see the kidney, you can even see up to the abdomen. But because 3D ultrasound is mostly enough, we say investigation of choice is 3D ultrasound. But if they say what else or what will you do if ultrasound is non-conclusive, then we'll go for an MRI. And so what we have discussed so far is we saw a small curved off midline banana shaped uterus, unicornuate. 40 to 70% patients of unicornuate uterus will have renal anomalies like we saw in our case, including ipsilateral agenesis, multicystic dysplastic kidney, ectopic position or renal fusion can also occur. Okay, so these are all the possibilities in this particular case. I will ask now Dr. Deepti to come back and take.
Two important things that I would definitely highlight, which Dr. Sumer has pointed out. Number one, if they ask you Mullerian anomalies or congenital Mullerian anomalies, do they cause infertility? The answer is no. Okay, so congenital Mullerian anomalies usually would not cause infertility. Okay? Please understand, they are incidental findings in women with infertility, but by themselves they don't cause infertility. Okay? The second important question, the second important thing that Sir highlighted is that there was ectopic kidney or ectopic ovary and an absent kidney. What do you need to know? ये दोनों ही चीजें, when we talk about absent kidney or we talk about ectopic ovary, ये कौन सी साइड पे होती हैं? The side of the rudimentary horn, या जिस साइड पे Mullerian duct develop नहीं हुई. So these pathologies are going to be ipsilateral to the anomaly. Okay, they are not on the contralateral side, they are on the ipsilateral side. ठीक है? So जिस साइड पे rudimentary horn है and the Mullerian duct did not develop, उस साइड पे you will see renal agenesis, you can see duplication as well, you can see an ectopic ovary as well. The third thing which Dr. Sumer has talked about, HST we were primarily doing for infertility and it picked up the Mullerian anomalies incidentally. But when you are suspecting Mullerian anomaly in your patient, okay, so when you are suspecting a Mullerian anomaly in your patient, what is the first investigation that you will do? It has to be a routine 2D अल्ट्रासाउंड. प्लीज सीधे अपने पेशेंट को एमआरआई के लिए नहीं भेज दीजिए. एमआरआई कर सकते हैं बट यू डोंट हैव टू स्ट्रेट अवे आस्क हर टू गेट एन एमआरआई डन. सो द फर्स्ट इन्वेस्टिगेशन इज अ रूटीन अल्ट्रासाउंड. It many times it will actually just tell you what it is, but because the contour is much more, better delineated, we say the IOC is going to be a 3D ultrasound, right? And as Dr. Sumer said, if the 3D ultrasound is also not able to make a diagnosis, or if we need additional information, right, then we go ahead and do an MRI. So among the radiological investigations, we say the gold standard is MRI, right? So among all the radiological investigations, we say the gold standard would be MRI. कभी कभी बहुत रेयरली ऐसा होता है कि MRI में भी मुझे कुछ डाउट है, या फिर I want to see more details to plan treatment in my patient. Then the best investigation is to see it yourself with your own eyes intraoperatively, right? So the best thing to look for the anomalies, to look for other associated findings, and to plan the treatment for my patient is a combination of laparoscopy and hysteroscopy, right? So then I would actually plan doing a laparoscopy with hysteroscopy. Akele nahi. Akele hysteroscopy may not be useful. See, the idea is that the lab will show you the contour from outside. It will also show you the structures on the outside, which is the ovary. And if you want to go into more details, you can see the pelvis, right? And hysteroscopy is going to show you the inside of the cavity. So we need to look at the fundus, as Dr. Sumer mentioned, and then we need to look at the inside of the cavity as well. Okay? So then the best is going to be, laparoscopy plus hysteroscopy. But as you all know, that is the most invasive investigation. So this is not something we do initially. It is a stepwise algorithm we follow to evaluate patient to decide on the mode of treatment or modality of treatment. Okay? Now, let's go on to the next question. The next question says, which Mullerian anomaly results from complete failure of fusion of the Mullerian ducts, right? So the key word here is complete failure of the fusion. Yes. So that is very often the words they will use in the MCQ. So the anomaly is also shown in the sonogram. Now Dr. Sumer has made you an expert. So can you tell me what ultrasound is this? It's really pretty, isn't it? So it is a 3-dimensional ultrasound, right? So this is the 3D image. And what is the answer here? Yes, so this is a uterine didelphius. Okay, why do we say it's a uterine didelphius? Let's understand this. There is 2 uterine horns. Yes, there are 2 cervices. Okay, and then you see a common vagina. So 2 uterine horns, each with its own cervix, and then they have a common vagina. So as a definition, what is didelphius? So जैसे मैंने बोला, as far as the definition of didelphius goes, there is 2 uterine horns or 2 uteri, right? There will be 2 cervices and 1 vagina. But now comes the very important thing I'm going to tell you. Although by definition it is supposed to have 1 vagina, but lot of times when you are investigating these patients, you will see that they show a double vagina. Can you think of the reason why? So madam, you said it is supposed to be a single vagina, but in the MCQ it said double vagina. So why? Because very often, okay, didelphius will have what? A vaginal septum. Okay, so very, very often a didelphius will have a vaginal septum, and that is why आप में से कुछ बच्चे ऐसे हैं जो बोलते हैं didelphius will have 2 cervix, 2 uterus and 2 vagina. So वो इसलिए है because it is very often going to have a septum. अब फिर से मेरी बात ध्यान से सुनेंगे. A lot of times this is a vertical septum, but, okay, and that is why you see a double vagina. But when we talk about didelphius, इट हैज हाईएस्ट, बेटा ध्यान से सुनोगे मेरी बात क्योंकि ये यूनिक चीजें हैं अबाउट दैट अनोमली. सो इट हैज हाईएस्ट एसोसिएशन विद अ ट्रांसवर्स वेजाइनल सेप्टम. अब मुझे आप बताओगे व्हेन देयर इज गोइंग टू बी अ ट्रांसवर्स वेजाइनल सेप्टम तो क्या होगा? ऑब्स्ट्रक्शन ऑफ द हेमी वेजाइना. सो एक वेजाइना पेटेंट होगा और एक वेजाइना obstructed hoga, right? So it can very often be associated with obstructed hemivagina. Yes? So which means, now if I ask you, if it is going to be associated with obstructed hemivagina, can it also be a cause of hematocolpos? Yes, it can. So this collection can drain through the other vagina, but it can get collected as well, right? And also, if there is obstruction, I told you it will lead to retrograde menstruation and it will lead to endometriosis. So this was NEET PG 2021. Yes, so you have to know that there is a possibility of endometriosis with didelphius as well, okay? Now, coming to clinical aspects, apart from these two things, you should know amongst all Mullerian anomalies, if we ask you which one has best, okay, best reproductive outcome, तो उसका आंसर क्या है? So among all anomalies, the best reproductive outcome is with didelphius. Okay? इसीलिए majority of times if we ask you does didelphius need a corrective surgery, the answer is no. So because it has the best reproductive outcome, usually corrective surgery bacha is not required. But now I ask you, acha bhai, the reproductive outcome is best, but can it cause certain obstetric problems? Yes or no? Can it cause certain obstetric problems? So the answer is yes. Okay. So the answer is yes. So arcuate, कुछ बच्चे लिख रहे हैं बेटा, arcuate no longer is considered as a anomaly. I hope you remember. I told you arcuate is now considered as a variant of normal uterus. So we no longer classify it as a Mullerian anomaly. Older classification में it was an anomaly. Now it is considered as just a variant. इसीलिए मैंने लिखा amongst the anomalies the best one is with didelphius. ठीक है? Okay. So now if at all didelphius will cause certain obstetric problems, which one is it going to be? So can it cause abortions? हाँ जी. Please don't think कि मैडम ने तो बोला था abortions are highest with septate. That's true, but I said all Mullerian anomalies can cause spontaneous abortion. So it can also cause abortions. Can it cause preterm labor? Yes. So again, although दो uterus हैं, but दोनों छोटे हैं as compared to one uterus. So the capacity is smaller, so it can lead to preterm labor, and therefore it can also lead to IUGR, right? So it can also lead to IUGR. Which malpresentation again would you see in didelphius? So again, इस साल का MCQ 2021 NEET PG. So ये क्या करेगा? Breach. Again, because the space is less, the baby cannot go in transverse lie. ठीक है? So यही क्वेश्चन था ना, which of the following is not an association with didelphius? So many of you marked it as endometriosis, जबकि आंसर क्या है? Transverse lie, right? So it is not associated with transverse lie. Now you will listen to me very carefully. Didelphius में दोनों Mullerian ducts बन रही हैं, right? They are not just fusing. Is it associated with, if I ask you renal anomalies? Yes or no? Yes. So even didelphius can be associated with renal anomalies. अब ये कौन सी तरफ होंगी? जिस तरफ का obstructed hemivagina होगा, right? So on the side of the obstructed hemivagina, you can definitely come across again what? renal agenesis. So renal agenesis definitely is higher with uniconnuate, but it can also be an association with didelphius. ठीक है बच्चा? So it can also be association with didelphius. Is that clear to everybody? And didelphius में जब हम clinical examination करते हैं, so when we are trying to do a per speculum examination or a local examination, we will quite often see two vaginas, और अगर vagina एक होगा, when you do a per speculum exam, you will see two cervices, है ना? So you will see two cervix. So उसी वक्त हम सोचना शुरू कर देते हैं that this is likely going to be a didelphius, although clinical examination by itself is not confirmatory. But when we see two cervices, one thing that comes to our mind is probably a didelphius. ठीक है बच्चा? So now I'm going to call Dr. Sumer, and he is going to talk to you about the radiological aspects of didelphius. Okay?
Okay, everyone. So didelphius is the one which is not very difficult to diagnose. You can see two uterine horns. Can you name the investigation in which I am showing it to you? HSG. You can see two widely diverging uterine horns. You can see the tubes on both the sides, two cervix and two vaginas. You can actually see the cannula is now put in one, so we must have put one by one in each each cervix. We have put the cannula separately. So this is uterus didelphius. Now, if I draw a diagrammatic representation, this is what Dr. Deepti meant. You have two uterine horns, two cervices, and you can see you can have a septum in the vagina. And you can see here, if this is a longitudinal septum, but I want you to see this one. Do you see this one? This is the transverse septum. I am zooming it for you. This is the transverse septum. So this patient, now imagine this patient has a transverse septum in the left hemivagina. So this part will get obstructed. So this is where you can develop hematocolpus and retrograde flow of the blood here. So this is very important, that you can have a transverse vaginal septum in uterus didelphius. Are you clear, everybody? Okay. So let's try to understand it, that how will we see it on other imaging. So if we see it on MR imaging, this is a MRI image, a coronal kind of a MRI section. I want you to see with me uterine horn. Can you see they are widely separated? You can see a notch. They are widely separated, and not only that, you can see there are two cervices which is marked by the arrowhead. Two cervical cavities, two uterine endometrial cavities, widely separated. And when we go further down and we take a section at the lower level, we can see a septum dividing the vagina into two cavities. So you can see actually two hemivaginas divided by a septum here. So this is the beauty of MRI imaging, that we can see on MRI the anatomy very, very clearly. And if we do an ultrasound in this particular patient, again you will see two different uterine cavities, and you can see some echogenic. This star marked area is some soft tissue or fat. So because they are two separate horns, so there is some soft tissue in between them. And sometimes you can see a pregnancy in one of the horns. So this is one of the horn, there is a gestational sac, the other horn is empty. So sometimes you can see such anatomy on ultrasound. Are you clear, everybody? And this is what we mean by uterine didelphius. When you do a laparoscopy, you can see two separate uterine horns widely separated from each other. Okay, everybody clear? So are you clear with this? Okay, so the image that I feel they will ask you will be HSG. Now the interesting thing is, although the investigation of choice is 3D ultrasound, or the best would be MRI, even better than 3D ultrasound, the MRI would be even better to solve the problems. But in the exam, they will show you HSG images, because you are not at the topmost level of the food chain in healthcare, you are at the MBBS level. They want to show you HSG image most of the time. So don't get confused. Exam में image HSG का आएगा, लेकिन IOC पूछेंगे तो 3D ultrasound mark करना है. Okay, so don't get confused there. So I'll ask Dr. Deepti to show you the next question.
All right. So I am back, and let's go on to the third MCQ that I have for you. So let's look at this. So the MCQs that we've got are not really difficult. We wanted to ensure you that you understand the concepts, and once you do that, no MCQ should sound confusing. Sometimes the options are confusing, but then if you know your content deep good enough, it should be easy to rule out the confusers. Now, we are saying we've already given you the diagnosis here. So a lot of times the NEET PG people do that. They start the MCQ with the diagnosis. So a septate uterus has been shown below, and we all know that it has significantly higher abortion rate, right? So please, somebody was asking me to repeat this as well, so I'm repeating it now. Septate uterus has the highest risk of recurrent pregnancy loss, or in other words, it has the highest association with recurrent pregnancy loss, right? Now, we are asking you, what is the primary mechanism thought to be responsible for this extraordinary high pregnancy loss rate? So, tell me, what imaging modality is this? Anybody? Again, it's actually a very, very clearly delineated contour of the uterus. This is again a 3D ultrasound. So you see the outer contour of the uterus is absolutely normal, which means the fundus is convex. Yes, so it is convex upwards. So the fundus is not having a dip, right? And then what you see is this septum. Okay. So it is going like this. So, right, so this is what you see. In fact, Dr. Sameer will talk to you more about what are we measuring here, right? So we see the depth of this dip, right, on the 3D ultrasound. But then I will leave that to Dr. Sameer. But let's go back to the question again. So, what is the reason? Yes, you're all right. The answer is partial or complete implantation on the largely avascular septum. So it's very essential that you understand that this septum is what? It is avascular. It is basically a fibrous tissue. So if it is fibrous tissue, it is not able to support the pregnancy, and there is recurrent pregnancy loss. अब मुझे जानना है, let me see how many of you try and put your thinking caps on and you tell me what is the reason for pregnancy loss in other anomalies. So हमने बोला other anomalies also, when it is uniconnuate also I said abortions, when it is didelphius also I said abortions, even in bicornuate there are going to be abortions. So यहाँ हमने बोला implantation on the avascular septum. तो फिर मेरे बच्चे, what is the reason for abortion in other anomalies? Can you tell me? Can you put your thinking caps on and tell me? So very essential. The other reasons for abortions, okay, are, okay, so one of the reason is correctly pointed out. It is going to be, yes, a reduced space, right? So distortion of the cavity or a reduced space. Yes, that is one. Anything else that you can think of? So distortion of cavity or reduced space. भाई अब अगर यूनिकॉन्युएट यूट्रस है और क्या हो सकता है उसमें? स्पेस कम हो गई और क्या हो सकता है? Do you understand that in uniconnuate a lot of times there is anomalous distribution of blood flow also to this anomalous uterus. Okay, so anomalous distribution of the uterine artery. Okay, that is another reason. Can you think of third reason? What is the third reason? So very, very essential, and I want you all to keep it in mind. Mullerian anomalies can also have, because they are extending onto the cervix as well. So kya hoga? Very commonly they would be associated with, yes, cervical incompetence, right? So they themselves can cause cervical incompetence, which is congenital. Now you are going to answer an applied MCQ from the concepts that I gave you. Okay, your applied MCQ is Mullerian anomalies in general. Okay, in general, Mullerian anomalies will cause which trimester abortions? Anybody? It will cause which trimester abortions? So now you know the cause, you know the etiology behind it, and I am sure once you apply it, you will give me the correct answer. So will they cause first trimester abortions or will they cause second trimester abortions? So yes, very good, excellent. They will cause more commonly second trimester abortions. Okay, so they can cause first also, but as a characteristic event, we say they will cause second trimester. बहुत अच्छे, शाबाश मेरे बच्चों, right? But when will the general answer change? So हमारे medical science में ऐसा होता है कि हम आपको कुछ general पढ़ाते हैं और फिर हम आपको उसके exceptions भी दिखाते हैं, right? So everything will have some of the other exception in medical science. That's the beauty of human body. So when would this answer change? When the question is not a general question. So when the question becomes more specific, and if they ask you, septate uterus will cause which trimester abortions? Now what would the answer be? Yes, excellent. So septate uterus, मेरे बच्चा, will more likely to cause first trimester abortions. ठीक है, इसका मतलब ये नहीं कि वो सेकंड नहीं कर सकता. सो यहाँ पे कुछ भी एब्सोल्यूट नहीं होता बेटा मेडिकल साइंस में. सो व्हाट वी आर राइटिंग इज व्हाट यू सी मोर कॉमनली इन क्लिनिकल प्रैक्टिस, विच इज व्हाट इज क्लिनिकली सिग्निफिकेंट. आप लोग अब बिल्कुल तैयार हो ओपीडी शुरू करने के लिए और मेरे पास पेशेंट्स भेजने के लिए, राइट? सो आप डायग्नोज करके मेरे पास भेजते रहो. नहीं, पहले सर के पास भेजना, रेडियोलॉजी कराएंगे, फिर मेरे पास भेजना, हम इलाज भी करेंगे. सो नाउ टेल मी, septate uterus unfortunately has the worst reproductive outcome. Yes, so it actually has the worst reproductive outcome, and therefore we want to improve this woman's reproductive outcome, and that is why you're going to send her to me. Yes, so what am I going to do for her? So for the septate uterus to improve the reproductive outcome, we are going to do what? We are going to resect this septum. Okay, we are going to remove the septum. So these days the treatment of choice, yes, so these days the treatment of choice becomes what? Hysteroscopic resection of septum, right? So hysteroscopic resection of the septum. Hysteroscopy is a procedure that you do transcervically. So you put the hysteroscope through the cervix. Isiliye, another term that you would see in your MCQs is transcervical, right? Resection of the septum, right? They can also put it as what? So if they don't use the word resection, they can put it as septoplasty, right? So transcervical septoplasty, transcervical resection of the septum, or hysteroscopic septoplasty, they would mean the same thing. They're just different ways of putting it across to you. Okay? Now, please remember, this is what the septate uterus looks like. Okay? But I have to tell you a little more detail on this, otherwise you're likely to do certain MCQs wrong. Let's understand this. Normally it is like this: the uterus will have a septum inside the cavity. The outer contour is absolutely normal, but what I want to tell you here is that this septum ka length is variable. Okay, so it can be small, it can be long, and it can be complete septum as well. For example, there is a possibility that this septum will also extend into the uterus. Not just that, it may often extend into the vagina. So there is a possibility that you are seeing a double vagina and it's not didelphys. So yaad hai, abhi thodi der pehle I taught you, if you're seeing a double vagina, the first thing that comes to my mind is didelphys. But as I say this, there is a very high probability that this septum is complete because there is a failure of canalization of the genital tract. So it may run throughout the uterus, the cervix as well as the vagina. Okay? So there is a possibility of this as well. Or isiliye, please remember this, since majority of times the septum is like this, can you now tell me, although it is going to cause abortions, can it cause preterm labor? Yes. So this will totally depend on the length of the septum. If the length of the septum is long, again the space becomes less and it can cause preterm labor as well. Okay. Then, can it cause obstruction or hemivagina? Yes. Less likely. But even septate uterus can sometimes cause obstructed hemivagina, mere bache. This is not the most common presentation. That is abortions. But sometimes even this can cause obstructed hemivagina. Kyun bata rahi ho? Kal ko exam mein you get a question, can septate uterus cause endometriosis? What will you say? Yes or no? The answer is yes. It is a less common finding, but even septate uterus can cause endometriosis. Okay, so these things will depend on how long the septum is and where is it extending to. Now, majority of times it's only a partial septum. So this is what it looks like. Can you tell me which malpresentation are you likely to see? Which malpresentation? So it's like this. It's more favorable for the baby to sit like this in this uterus, right? And therefore we say the malpresentation we are more likely to say. I'm not saying that the others can be seen, but the more likely one here is going to be transverse lie. So please remember that in uniconnuate, in didelphys, it usually turns out to be breech. In septate, as well as in bicornuate. Okay, bicornuate, Dr. Sumer abhi dikhayenge. Right, so this was the last MCQ, but I'm covering a lot of other MCQs for you in the integrated round. Okay, so a bicornuate looks very similar to the septate from inside. Yes, so if you only focus on the cavity, in both of them, the cavity has a projection. The difference is the fundus. So, DD of septate is going to be a bicornuate uterus. In fact, septate is the most common anomaly in general, and bicornuate is the second most common anomaly. Okay, so most common is septate, the second most common is bicornuate. Okay, and remember this, even in bicornuate there is a projection in the cavity, so again the baby is more likely to sit like this. It has more space if it sits like this. So even here it is more likely to be transverse lie. Okay, and in bicornuate again, generally what do you see? There are, one uterus, but there is a division in the center. So if you look in the cavity, it looks like two cavities. Yes, there is one cervix and there is one vagina. Okay, so there is one cervix and one vagina. So the only way to differentiate a septate from a bicornuate is actually to look at the fundus, right? So those are very, very important things. Before I hand over it to Dr. Sumer, I just want to tell you things that you should also know about bicornuate uterus, right? So generally, again, bicornuate has a good reproductive outcome. Not as good as didelphys, but yes, it also has good outcome. So generally speaking, no corrective surgery is required. But can you tell me if bicornuate, okay, if bicornuate is more likely to cause certain obstetric complications, which ones are they going to be? So yes, as I said, it can cause abortions, it can also cause preterm labor, and it can definitely cause malpresentations, right? Which I told you is more likely to be ट्रांसवर्स. देखो आप लोग उल्टा बात क्यों पूछते हो? मैं बोलती हूँ इट इज मोर लाइकली टू बी ट्रांसवर्स, तो आप पूछते हो can it be breach also? It can be anything in medical science. But what you are supposed to answer in the exams is what is more clinically significant, what you and I are going to see in the wards, in the OPDs, in the OTs, right? So please understand this. NEET PG exams ho ya INICT ho, they don't want you to think of vague and all possible rare outcomes. They want you to think on simple lines, no overthinking. Anything is possible in medical science, right? If you go and open a journal, you may find evidence of everything. But what we are more going to answer if they ask which malpresentation would you see in septate or in biconjugate, you should answer it as transverse lie. Vice versa is not true. I'm not saying breach cannot happen. Okay? So abortions, preterm labor and malpresentation. If my patient has recurrent preterm labor, okay, so if it has, or if she has recurrent preterm labor, or if she is having recurrent abortions, yes, then how do we improve the reproductive outcome? So then, to improve reproductive outcome, I am going to join the two cavities and make a big one out of it. Yes, so this is what is called as what? This is what is called as, yes, metroplasty. And we name it after the surgeon who had given the surgery. So it's called as Strassman metroplasty, right? So it is called as Strassman metroplasty. Is that clear to everyone? So I'll hand over the mic to Dr. Sumer and he's going to talk about septate and biconjugate together, and then I will summarize the most important things for you as far as clinical application is concerned.
Okay, so we have already seen the two common questions from radiology will be either unicornate uterus or a uterine didelphys, which we saw in the imagery before in the previous discussion. And Dr. Deepti has already told us that we have to differentiate between bicornuate and septate uterus by looking at the fundus and looking at the outer contour, not the inner. So you cannot see it from the inside, you have to see it from outside. That is where, HSG is unable to tell you if we are looking at a septate uterus or we are looking at a bicornuate uterus. We need to do a test which can show us from the outside the contour of the fundus, and that is where there is role of things like 3D ultrasound, things like MRI. I will show you, okay, I will show you and we will talk about it together. So let's see the first image, a theoretical image in front of you. You can see the vagina, cervix, uterus, uterine cavity are actually joined at the end. But what do you see here? There is a dip in the fundus. Now, can you tell me what are we going to talk about? This must be a bicornuate uterus because the fundus is not flat. There is a dip in the fundus and there are two cornua. But the cervix is one. Actually, even the lower part of the uterus, endometrial cavity is fused. The cervix is one, vagina is one. So this is a bicornuate uterus. So when you look at bicornuate on a MR image, this is how it would look like. So this is one uterine cavity, second uterine cavity, fusing here. This is one uterus from the outside, and this is the other uterus from the outside. So this is not didelphys, because in didelphys we saw the uterus were widely apart. The uterine horns were widely apart, and even the cervix was separate, and we could see a vaginal septum as well. Here only there are two uterine horns. This is two horns which are separated like this, but this is not fully separated. So this is a bicornuate uterus. This is a bicornuate uterus on MRI. If you do a 3D ultrasound in this patient, what will you see? I want you to see that this is your endometrium. You can see two endometrium cavities fusing here. And I want you to see the outer aspect of the uterus. Somebody was asking in the chat box earlier also, look at the outer aspect of the uterus. I am tracing it for you. And you can see the dip in the fundus. You can see the dip in the fundus. What do you think this is? Bicornuate. Why? Because when you look at it, the fundus is dipping down. Are you clear here? There is a dip in the fundus. This is bicornuate uterus on a 3D ultrasound. Okay? Are you clear? But the question is, how do we differentiate a bicornuate and a septate uterus? And that is what we want to see together. Now, this is an example of an image. I want you to see this image with me. Okay? This is the outer part of your uterus, outer part, the fundus, and like this. So what do you see? So here if you notice, the fundus is flat. There is no dip in the fundus, but there is a septum dividing the uterine cavity, extending actually till the cervix in this patient. This is a complete septum going from the uterine cavity till the cervix in this patient. What is this? Because there is no dip in the fundus, this is a septate uterus. Okay, this is a septate uterus. Now let me show you how it would look like on a HSC. So let us see an HSC image. What do you see? Now this is the problem with HSC. Now when I see HSG here, you can see one uterine cavity, another uterine cavity, single cervix, single vagina. What do you see here? Now this looks like either this could be a bicornuate uterus or it could be septate. We cannot tell because on HSG we cannot see the outer aspect. We are only seeing through the cavity. We are unable to see the outer aspect of the uterus. So this is the drawback. That is why HSG is not the investigation of choice for these conditions, because it cannot evaluate the uterine fundus contour. So the statement that I want you to read with me is, HSG cannot be used to evaluate external uterine contour, therefore does not allow reliable differentiation of septate and bicornuate uterus. Everybody clear? Okay, are you clear? So, many times I see, the interesting thing is, many times I see students will send me a message and say, sir, ये देख के बताओ septate है कि bicornuate है. मैं कह रहा हूँ मेरे को नहीं समझ आ रहा, मैं नहीं बता सकता. तो बोला नहीं सर एग्जाम में आ गया. तो मैं बोला एग्जामिनर कोई बेवकूफ थोड़ी है जो पूछेगा, जो बता ही नहीं सकते वो थोड़ी पूछ लेगा. So sometimes I again want you to know, if you are a medical student, okay, you are supposed to think in correct directions. If you think in infinite, unknown and unusual directions, you will end up marking questions wrong because of the confusion that you have in your mind. We have to reduce the noise at the junior level. When you become senior, maybe you have to look for rare diseases also, but not at this juncture in your life. You have to evolve. पहले basic सीखेंगे, फिर थोड़े से और आगे जाएंगे, फिर rare चीज पे आएंगे. Okay. Now, second question. Okay. Second question is, historically, people used to say that if the angle is less than 90 degree between the two uterine horn, we will call it septate. But it is inaccurate. It is not a reliable criteria. But historically, people used to say that on HSG, if the angle between the two uterine horns is less than 90 degree, it is septate. If it is more than that, you will call it bicornuate, but this is inaccurate and this is not reliable diagnostic feature. So today we will not go with it. So I will show you the image that I want you to see. I am sure you want to see the 3D ultrasound. Okay, I will just bring a 3D ultrasound for you. Okay, now please see this 3D ultrasound with me. There is definitely two uterine cavities fusing here in the lower part, fusing at the cervix is single, So we're thinking either we're dealing with bicornuate or septate. Look at the outer uterine contour, outer uterine contour, outer uterine contour. Okay. So if I draw a line joining the two cornual ends of the cavity here, and I find that the uterine fundus is more than 5 millimeter above it, this is septate uterus. I will write it down, don't worry. So what I'm saying is, if you draw a line between the uterine ostia, apex of the external contour is more than 5 mm, it is septate. Okay, I'm again repeating for you. दोबारा सोचो. देखो कैसे पता चलेगा? हमने देखा कि दो कैविटी हैं. There are two uterine cavities. Maybe it could be, but the cervix is single, lower part of the uterus is here. So we are thinking either bicornuate or septate. Now I want you to look at the outer contour, the superior contour of the uterine fundus. Draw a line between two cornual ends here. If the distance between this is more than 5 millimeter, that means we are dealing with a septate uterus. That means we are dealing with a septate uterus. Are you clear? Second line is, in a bicornuate uterus, apex of the external fundal contour is below or less than 5 mm above the interosteal line. That means between the two ostia, if you draw a line joining them, if your external contour is below this or less than 5 mm, you will call it as bicornuate. So if the key entire idea is, you have to look at the apex of external fundal contour more than 5 mm above the interosteal line is septate. Less than that, or if it is below that, you will call it bicornuate. Okay. Now I will show you one more image just to make sure that we are on the same page of understanding. This is a MRI image. So you can see there is something dividing the uterine cavity even up to the cervix. You can see something dividing it into two parts. Is it bicornuate? Is it septate? Now you can see the outer fundus, external fundal contour. There is no dip. It is absolutely normal, telling you that we are dealing with a septate uterus on a MRI imaging. So the entire key is to look at the outer or the external fundal contour to differentiate between a septate and a bicornuate uterus. So that is why HSG is suboptimal. HSG is unable to tell us. Okay, everybody clear? Okay, so once you are able to understand this, I will leave you with a thought and I'll ask Dr. Deepti to give concluding remarks. The idea here is that the idea that I want you to have is that on every Tuesday, we are giving you a two-teacher perspective. Two-teacher perspective to MCQ, which is integrated. It happens every Tuesday. You can see the previous ones also on the app. There are multiple there. I think there are very, very rich resource of knowledge. Every Wednesday, we are doing a clinical grand round. Don't make notes here. It's not required. Just listen intently. What will happen is, because in these integrated rounds we have the time, because we are only looking at one particular clinical case. So as a teacher we go deeper into explaining it with clinical perspective. And I think if you understand the clinical perspective, it becomes very easy for you to retain. So my understanding is, and this is what I truly believe in life is, if this is your brain, and I'm going to hand over to Dr. Deepti because now I have to, have my dinner also. Dr. Deepti, if I delay it longer, she will not give it to me. So I'm going to finish it very, very fast. So this is your small area in your brain called as hippocampus in the mesial temporal lobe. And your entire brain has interconnections. So entire of your brain matter or the gray matter is connected with association fibers, commissural fibers, different fibers are there. Now what is happening is, memory is stored in this small area called as hippocampus, while understanding is stored in interconnections between different areas of our brain, which we call, in terms of psychiatry, we call it as subconscious. So what happens here is, I want you all to follow that. What is my purpose of doing all these integrated rounds and clinical rounds? My purpose is to help you build your subconscious understanding. Subconscious understanding is just like riding a bicycle. You don't need to revise it. Do you revise? Like, last time I had, I was riding a bicycle, was in my school. Recently I went to a place where there were bicycles and I was riding a bicycle. I did not need to revise it. It is there in my subconscious. I know it. Similarly, what you understand clearly will stay with you in your subconscious and it will come out when it is asked in the exam. Memories is a weak tool. We tend to forget, and actually we must forget most of the times, because that is the law of nature. You cannot remember everything. So we are all programmed to forget. So if you trust memory, you are in for a surprise in medical science. You are at a postgraduate level. Here the key is understanding. The key is not in memorizing. I am again saying, many students they come and say, sir, मैं हाथ रख के बार-बार याद कर रहा हूँ नोट्स को, मैं एक दिन में 15 बार कर रहा हूँ. बात नहीं बनेगी. It's not about it. एक बार करेंगे, याद करने की जगह समझ लेंगे, it will be with you forever. So that is the entire purpose. Memories are temporary, understanding is permanent. I invite Dr. Deepti now to, give the final remarks about the case.
All right, so I am back after Dr. Sumay's pep talk and his wise words, which he is always full of. So now we just a moment. Okay, so now I'm just going to summarize the things for you. Now we have seen all anomalies, separately. Okay, so we talked about them one by one. But what I want you to know is certain common things that I want you to know when we talk about Mullerian anomalies, and they should come to you naturally. Okay? So, सबसे पहली बात है that almost all Mullerian anomalies, without any exception, they can cause obstruction of vagina or hemivagina, right? So that is always a possibility. So stop asking me, ma'am, can we see this in septate? Can we see this in biconjugate? Yes, you can even see obstruction of hemivagina and vagina in septate and biconjugate as well, but they are less common there as compared to uniconjugate or when it comes to didelphius. Okay? So, if they are going to cause obstruction of hemivagina or vagina, तो फिर सारे ही ये क्या करेंगे? They can cause cyclic pelvic pain. So, one of this is going to be cyclic pelvic pain is the presentation in the MCQ. The other things is that they can present with hematometra, which is a collection in the uterus, and hematocolpos, which is a collection in the vagina. Now, since it's an hematometra, therefore the presentation can also be of a abdominal mass or an abdominopelvic mass, right? So this uterus can be palpable per abdomen. ठीक? दूसरा, the next thing is these Mullerian anomalies, because they are associated with obstructions and other things, they can also present with abnormal bleeding. The moment I say abnormal uterine bleeding, it can be in both extremes. It can be less flow, okay? It can be more flow, right? So, दोनों तरह के ही abnormal bleeding we can come across. So, sometimes because of the obstruction, the flow can be less. Sometimes the flow can be more, right? So, both kinds of abnormalities can be seen. Then, because there is obstruction, the collections can always get infected, है ना? So, they can also present with genital tract obstruction, infections. Okay, so they can also present as a genital tract infection. And as I said, a lot of times the vagina can be a septate vagina. We've seen more commonly with didelphius, but as I said, you can see it with septate as well. You can see it with biconjugate as well. So, if there is a hemivagina or a septum in the vagina, they can also complain to you of dyspareunia. Okay, so that is painful coitus. Now, because of its high association with urinary tract anomalies or renal anomalies, we have already talked about, but you should know what are the other associations of Mullerian anomaly. So apart from renal, what you're also likely to see is skeletal anomalies. You can also see anterior abdominal wall abnormalities. And you can also come across, you all know, inguinal hernia, right? So that's something we see with Mullerian agenesis or other such conditions. So you can come across inguinal hernia as well. Okay. Then as far as obstetric outcomes are concerned, what did I say? So in general, bacha, Mullerian anomalies do not cause infertility. They are incidental findings in women with infertility. Okay? So what are they more likely to cause? The woman will conceive, but then she will have abortions or recurrent abortions, right? So abortions or recurrent abortions, we saw almost all of them can cause preterm labor because of the small space IUGR. Then I said they could be associated with cervical incompetence, which itself was one of the explanations for abortions. Because of their high association with malpresentations, there is increased risk of cesarean sections, है ना? So cesarean का भी incidence ज़्यादा होता है. फिर और क्या होता है? Very, very important, abnormal placental attachment. So when we talk about placenta previa or when we talk about placenta accreta spectrum pass, right? So placenta previa, placenta accreta spectrum, they also are seen in women with Mullerian abnormalities. Okay. Then who is going to tell me why would they cause PPH? Why would they cause postpartum hemorrhage? So this is the reason. So because of abnormal placental attachments, they are at a high risk of having postpartum hemorrhage as well. Let me see how many of you can put your thinking caps on and tell me why are they also at a slightly higher risk of developing preeclampsia or हाइपरटेंशन इन प्रेगनेंसी. कौन देगा आंसर? और मेरी क्लास में हमेशा एक चॉकलेट क्वेश्चन होता है और ये आज का चॉकलेट क्वेश्चन है. सो हु इज गोइंग टू टेल मी व्हाई एम आई एसोसिएटिंग Mullerian anomalies with preeclampsia or hypertension? So the chocolate goes to, let's see who's the first one to fire. Tell me, I am waiting. Yes? और जब तक आप मुझे ये बता रहे हो, I will also say they can also cause rupture uterus, which is typically seen when the pregnancy is in the rudimentary horn, right? So if the pregnancy is in the rudimentary horn of a uniconnuate uterus, then it can also lead to rupture of the uterus. So chocolate question का आंसर अभी तक नहीं मिला मुझे. Preeclampsia, hypertension. No, it is not abnormalities of the uterine vessels. A more obvious answer, a very obvious answer. So that is what is connecting the dots, and that's what Dr. Sumer was saying. अगर हम ये points ही याद करते रहेंगे, तो ऐसा लगेगा कि मैडम ने तो 10 लिखवाए थे और मुझे सिर्फ 5 याद आ रहे हैं. So that is a cause of distress, anxiety, yes, self-doubt. So let's try and connect the dots. Tell me. अच्छा ऊपर, हाँ देखो Dr. Sumer is able to connect because he is thinking like a student right now. So he's sitting here with me. He's not thinking like Dr. Sumer. He is thinking like a student who I'm teaching. So what is the answer? Yes. So Siva Subramaniam gets the chocolate of the day. Dr. Sumer doesn't get it. But Siva Subramaniam, excellent. Yes. Because of high association with renal abnormalities. Okay. So that is the reason why even slightly higher chances of preeclampsia or hypertension are seen. Okay, so this is in nutshell the clinical associations, the clinical findings, the clinical presentations that they can give you with a question on, Mullerian anomaly. Remember to go with common things first. For example, when we talk about endometriosis, think of uniconnuate first. Then think of didelphius. Then go on to septate and biconnuate. Similarly, when we talk about breech, first think of septate and biconjugate, then go on to, a uniconjugate uterus or a didelphius. Whereas when they talk about transverse lie, then think of, yes, the biconjugates first and septate first, right? So, common चीजों के बारे में पहले सोचेंगे, फिर देखेंगे कि yes, as exception, these things can be seen with other abnormalities as well. ठीक है? So, that is in the nutshell that you need to know for Mullerian anomalies. I hope, I'll just call Dr. Sumer, and I hope you found the session interesting, as well as you're now confident about the topic as well. Okay? So, in case you have any further doubts, you can always let us know, but I'm sure the things are more clear. You are able to connect the dots, as we said, and now whether the question comes as a radiological image or if it comes as a clinical presentation, you will be able to mark it right. So common चीजें पहले सोचेंगे, फिर दूसरी चीजों पे जाएंगे. Memory की जगह connecting the dots is the key. Okay?
And what I'll do is I'll leave you with an idea that I thought of. I was saying it earlier also. I'll say it again for the students who are, it's like what I feel is that success is actually more simple, and it is when we grow up we make it more complicated. Like when we were in school, we knew that कि अगर एग्जाम में अच्छा करना है तो पढ़ना पड़ेगा. Do you agree कि नहीं? है ना? स्कूल में थे तो पता था, मतलब आई एम श्योर यू ऑल नो दिस ऑल्सो कि एग्जाम में अच्छा करना है तो क्या करना है, पढ़ना पड़ेगा और अच्छे से पढ़ना पड़ेगा. टीचर्स को भी मेहनत करनी पड़ेगी साथ में, और हम भी मेहनत कर रहे हैं. रात को अब हम 11 बजे हम एक साथ पढ़ रहे हैं, वी आर ऑल वर्किंग टुगेदर, हम मेहनत कर रहे हैं, है ना. बट व्हाट हैपेंस इज व्हेन वी ग्रो अप वी गेट कॉम्प्लिकेटेड एंड वी स्टार्ट थिंकिंग कि सक्सेस मीन्स कलेक्टिंग स्टफ, एंड दैट इज वेयर थिंग्स स्टार्ट्स टू गो रॉन्ग. हमें लगता है कि कहीं मैं कुछ खो ना दूं, कुछ मिस ना हो जाए मुझसे, एंड वी स्टार्ट डेवलपिंग समथिंग विच इज कॉल्ड एज फोमो. फोमो इज अ मॉडर्न टर्म, क्लासिकल लिटरेचर में इसका कोई जगह नहीं थी, ये आज एक नई चीज आ गई. फोमो मतलब लगता है कुछ रह ना जाए, तो मैं सब किसी तरह से सब खरीद लूं, सब इकट्ठा कर लूं, एंड वी स्टार्ट बिकमिंग कलेक्टर्स, नॉट ओनली इन स्टडी, ऑल्सो इन लाइफ ऑल्सो. वी स्टार्ट अकोमुलेटिंग थिंग्स के गाड़ी खरीद लेते हैं, ये खरीद लेते हैं, इससे खुशी मिलेगी, उससे खुशी मिलती नहीं है, कि खुशी तो मिलनी है जब हम अपने सपनों को पाएंगे और हम लोगों के लिए कुछ कर पाते हैं. वी स्टार्ट फीलिंग मोर हैप्पी अबाउट इट. So what I sometimes I feel that it was all more towards simplifying things rather than making it more complicated. And it was not supposed to be complicated. It is just that you made it complicated. Now I would take a moment to tell you, last year's NEET PG exam, this year's NEET PG exam, last year's INICT exam, this year's INICT exam, every year's NEET PG exam, the questions are usually asked from usual topics. They are usually not complicated. They might be some questions which are discriminatory, like the one question that Dr. Deepti was talking about in the didelphys and the transverse septum, that was slightly on the complicated note. But usually they will show you things which are more doable, more usual. But if you make it more complicated, then it becomes tricky. So that is the entire purpose of these sessions that we are doing here, is to make sure that we are able to give you a simplified view of the clinical situation. And it is our purpose to make sure that we, hit your subconscious understanding. That is what my desire is. And I want you to know, I am today telling you this line, and you will be speaking this line when you come to give an interview to us later on, कि we will repeatedly hammer the usual things to you. कभी क्लास में, कभी क्वेश्चन में, कभी टेस्ट में, कभी डिस्कशन में, कभी जीटी डिस्कशन में, कभी इंटीग्रेटेड राउंड में, कभी क्लिनिकल राउंड में. वी विल कीप रिपीटेडली हैमरिंग यू, कभी डीवीटी में, कभी एम्स कैप्सूल में. Now, I have heard this line multiple times in the last 2 decades. The students will come and say, सर आप बार बार बताते रहते हैं, आप थकते नहीं है, हम थक जाते हैं, आप बताते रहते हैं, जब तक कि वो हमारे सिस्टम में अंडरस्टैंडिंग की तरह ना चला जाए. That is what we do, and that is what I want you to, learn from us. It is about understanding. It is not about memorizing. It is not about unusual stuff. It is about usual stuff. Success is actually about simplifying the problem. A great physicist, Richard Feynman, I don't know if you've read about him or not. Once he said that if you cannot describe a complex physics problem in simple words, If you cannot describe a complex problem in simple words, that means you have not understood it. That is the beauty of it. So on this note, I wish you all the best and ask Dr. Deepti to say a line and then we conclude the session today.
बच्चों को बहुत बुरा लग रहा है कि मैंने डॉक्टर सुमेर को चॉकलेट नहीं दी. वो इसलिए नहीं दी कि उनको खाना देने वाली हूँ. So I'm always more biased towards him. Don't worry. Okay. So thank you for all the love and it was a wonderful session. And Siva Subramaniam, I want you to send me a message right away on Instagram if you are there. I have to send you the chocolate and I will really send it. Okay. And not the virtual one. So I'll take your address. I'll send you a chocolate, but you have to take the one that I sent. Okay. So, and tell me that you like it. So all the very best. Take care, everybody. The end, point of today's class is think of common things, okay, apply rather than memorize, and try and put the clinical things or the so-called dots together to form a permanent image in your mind, okay. So take care, good night everybody, Shabba khair, bye-bye.